I am somebody who who doesn't like ACIs a lot, and a lot of cornea surgeons, including Anand, who is just spoken on the topic, would feel the same because a lot of times this does result in decompensation, and it's not an easy chance. It's not easy task to explant these ACIs. Evidently, you have to most of the times cut the haptic, and then take them out. So, what a situation that you don't want is something like this. You need as a backup option, particularly when you remove the whole bag or you cannot implant an IOL in the sulcus. So when there's a large PCR and aphakia, so what you should do is that you should not panic in this sort of a situation, and you should calm down, think, take for a couple of seconds, relax, and then take a decision. So what comes to the rescue is the claw. So I use the XL variety of lenses, and basically it has an overall length of 8 millimeters with an optic the size of 5.5 millimeters. It has a claw over here, as you can see in the picture. This is where you enclave your iris onto it. This is a PMMA based lens. So when it comes to biometry is extremely important over here. I use the XL lenses, which has an A constant of 117.2. So if you have if you calculated your IL as with an A constant of 118.7, then you can subtract minus 1.5, or you can basically subtract it from the IL constant that you have calculated the IOL from. So when not to do it, aphakia, which could be surgical or congenital disorders like Marfan syndrome, ectopia lentis, or even traumatic dislocated or subluxated lenses. And whenever there's a large zonal dialysis, then you cannot manage it with a combination of a CTR, CTS, or in the bag or a sulcus IOL. Contraindications would be any inflamed eyes such as active uveitis, rubeosis, iritis, excessive iris shafting or iridectomies, any angle abnormalities like PAS, and any posterior segment pathologies like a CME or a CNVM, etc. A relative indication and a contraindication could be pseudo-exfoliation, where these irises behave very abnormally, and therefore enclavation can be de-enclavation chances can be there in such eyes. So why an iris claw IOL? Because it is good to prevent primary aphakia, and you don't need any second or multiple surgeries. It avoids delayed visual recovery and also avoids the awkward situation with the patient. So it's a very good option, particularly as a backup lens. So prerequisites is that you need a physiological pupil, and you need an ample amount of undamaged iris tissue, particularly at the ends where you will be enclaving the haptics of this IOL. It is mandatory to do a good automated anterior vitrectomy, even if the vitreous face is not disturbed, because it basically then what happens is this vitreous can come later on also after enclavation of the IOL. So what instruments that you require is the IOL itself. You need some special iris claw forceps. These are the two designs that are available, and a Sinskey hook, or sometimes some people use a hydro cannula or a visco cannula for the same as well. People can use a McPherson's forceps instead of these iris claw forceps, but it's a little bit more technically challenging than this. So let's take a look at the surgical video. This is a video where it requires a scale tunnel to be made, and first thing you need to do is you need to check out that these haptics, the space is there in between them, or the gap is there or not. With a dial, it is put inside the anterior chamber to the correct orientation that you want. The iris claw forceps is grasped, and this I'm using a hydro cannula over here, and the enclavation is done. Remember, similarly same thing, you take this and you below the other side of the iris and enclave it. A very important point is a full thickness enclavation. If you don't do that, it is not going to give you the good results. Vitrectomy can be done with a vitrectomy probe, preferably, or with a. Let's take a look at another video, or you can also use. You do it manually also. So once this is another video where after creating of a scleral tunnel, you do need two side ports 180 degrees apart. AC maintainer can be used. Pilocarpine is actually indicated because you want the pupil to become more physiological. However, the smaller the pupil, it will make it a little bit more difficult to put it behind, but the enclavation would be at the mid iris plane, which is actually what is required in such scenarios. I'll move forward to the enclavation part. So you can go like this. Over here, I'm using a McPherson's forceps, and this enclavation is done on one side. And this enclavation, you can see it nicely once you zoom in a little bit more. And it can be done on the other side as well, followed by you do a iridectomy. Iridectomies are must to prevent the pupillary block. So tips are: enclavation should be done at the mid iris plane. Look and test for the enclavation and stability of the IOL. If it's partially thickness, you need to go in and enclave it full thickness. You have to always suture the scleral tunnel because it is a vitrectomized eye. Peripheral iodectomy is must, and vitrectomy is also very important, or anterior vitrectomy, even if the vitreous face is not disturbed. So this is another example of a post-DSEC iris claw oil. You can see some people may complain it will not give you a good mydriasis, but yes, mydriasis is possible if you very good in inclination, good mydriasis, particularly if you enclave at the mid-iris plane. So SFIL, as my colleagues have told, that sutured, they can have degradation by the sutures. Sutureless is a technically bit difficult, not for every anterior segment surgeon, but we have come out with a technique which is easier for the anterior segment surgeons, which Andrini will be showing, which is called the mixed technique. Certain studies have shown higher complication rates and need for resurgery, and due to this, basically because of suture breakage in SFILs, fewer studies have shown us they are associated with intraoperative and postoperative complications. The risk of RD is 4 to 6%. Other complications like ciliary body hemorrhage, CME, and all of these things have been reported. Although latest techniques are there, promising results, it does have a steeper learning curve than iris claw IOLs. Advantages of the iris claw IOL are that it's easy, fast, cheaper, minimum skill required, it is easily reproducible, and you do not need a retina backup in such cases. Questions what you would ask is whether pigment dispersion, any CME, what is the safety profile, and pseudophacodonosis. Pigment dispersion syndrome in iris claw IOLs is rare and a result of the intraoperative manipulation of the iris rather than the iris claw IOL itself. De-enclavation of one haptic has been seen in only 1% of the cases, and this is because you have not enclaved full thickness. Persistent uveitis, no cases have been reported. Ovalization of the pupil is seen in 10 to 15% cases. It is the most common complication that you see. However, it does not impact the visual outcome of the patient. Pupillary block rarely reported. However, PI is recommended. Raised IOP post-operatively is due to the retained OVD, and it is medically manageable. RD is reported as 0.3%. CME is not been reported in literature, and pseudophacodonosis doesn't occur when it is enclaved in the mid-iris plane. So to conclude, iris claw IOLs is a safe and a faster backup to manage aphakia. It is technically easier. It is as easy as seeing one. This is what my mentor, Dr. Aniket Shastri, told me, and I did this. In fact, I saw one, I did the next, and I trained the next. So this was 3 surgeries in one day. So automated anterior vitrectomy in PI are must and requires minimum instrumentation. It's easier than you think. Thank you so much.